All the trials that we have used lenalidomide, dexamethasone, or bortezomib, dexamethasone, but most of them are lenalidomide. So a lot of our patients are taking lenalidomide. How would you deal with that challenge, Gareth, when you're switching therapy?
So my practice is just a little bit different because we see a lot of younger patients and we're treating them to CRs. They're tending to relapse many years after they've come off the maintenance therapy. And so in that setting, the choice of agents is less of a problem. And so I think we would try and repeat the same sort of approaches up front, which is consider consolidation with transplant or non-transplant.
Tom, what about you? If you're on lenalidomide and you're progressing and you're in a community physician, what do you advise them to do? Do you just up the dose of lenalidomide, or do you switch to pomalidomide, or do you go with cyclophosphamide? And what's your...
I agree with Sagar that if somebody is relapsing on lenalidomide, I don't think going up to a higher dose of lenalidomide is going to get you a lot of distance. And so we switch to carfilzomib-based therapy or switch to pomalidomide plus antibody-based therapy.
Toxicity is the same for pomalidomide, lenalidomide. Any difference there?
I think that they're fairly comparable. If anything, pomalidomide is maybe a little better tolerated than len.
There's been some thought that there's a lot more neutropenia with daratumumab and pomalidomide. Have you seen that?
Yes. So in general, what we just like Sagar, we used a lot of dPOMD once that drug was approved for combination. We saw a lot of neutropenia and then started to use the 2 milligram as the starting dose, see how patients do with that first cycle, and if they're responding, that's fine. If they're not having optimal response, we can up the dose based on tolerability.
Does anybody? There's been a trial called Endeavour in which carfilzomib dexamethasone was compared with bortezomib dexamethasone, and maybe just to kick us off, do you recall? Do you want to summarize the results of that for us, Ivan? Can you remember?
So it looked, the carfilzomib arm clearly, I think, did better than the bortezomib arm.
It's almost a doubling.
Yes.
Would you consider using that in somebody who is intolerant of lenalidomide or the imides? I mean, how would you ever consider using a doublet therapy like that?
Yeah, I mean, I think you have to sort of personalize the treatment to what the patient can tolerate in addition to what the optimal therapy is. And I mean, there is data to show that there is a benefit of that combination, and certainly carfilzomib, lenalidomide is a reasonable one with dexamethasone, without dexamethasone, depending upon the toxicities, and we certainly have used it with good results.
Other comments on doublet therapy with high doses of carfilzomib? I mean, these are double the standard dose.
Every study that's been done comparing a triplet to a doublet has kind of favored the triplet. And the real question going forward is, can you go from a triplet to a quadruplet and maximize
But Gareth,
responses?
you've already pointed out that there are some economic concerns in many countries.
But some of these agents are going to be going generic in the next few years, which frees up economic space to move towards these regimens. And
there are also people who just can't take imides, right? They get rash or they have neuropathy. Or what would you do for them? Would you always use bendamustine or cyclophosphamide?
You could go for a three-drug regimen with daratumumab.
I mean, I think one way to think about that, if you're trying to use a higher dose of carfilzomib and still use it in a triplet without an IMiD, for us would be to combine it with panobinostat. And there is nice data actually from Jesus Verdeja as well as a couple other trials where you can do it on an every other week schedule so that you don't get as much of the GI tox that you got with bortezomib, and that has pretty reasonable efficacy as well.
You can do the panobinostat like every other week, yeah, with standard carfilzomib. So it's interesting with carfilzomib. I don't know about your guys' practice, but for me, there's only 2 doses of carfilzomib. It's either 60 milligrams or you're giving them 2 vials, 120 milligrams. There's no 36 per meter squared in my mind. There's no 45. There's no 56. You give them the whole vial.
Now you're going off the reservation here. So let's stick on our. I don't disagree with you, but we should probably stick on the label dosing for these things. There is a bit of confusion about the dose, so I think that's true. And most of us are using, I think, 36 milligrams per meter squared or some equivalent to that, right? What about, I want to come back just a minute to renal failure patients, and there's been some talk that you can't use lenalidomide, and there's been a little bit of nervousness around using carfilzomib in those patients. What's your take on that? Is pomalidomide safe to use there? Do you use carfilzomib in renal failure, Sagar? What do you do?
Yeah, I mean, I think you know, the advantage of both of the proteasome inhibitors is that they are renal function independent. So I don't have an issue using carfilzomib.
But the creatinine can go up if you use carfilzomib.
It can, but that doesn't mean that you don't do it. It just means you watch it and you're careful with it. I think with POM, there is actually data actually from a precog study that suggests that unless the creatinine clearance is very low, you go with full dose pomalidomide, similar to what you do with thalidomide. So I think there are ways to do it. I think with Len, from my view, until you know where the kidney function has stabilized, if it's going up, then I'm a little hesitant to use it because chronic myelosuppression is really the issue, and that limits your ability to continue them on therapy. But if it's a stable creatinine, then I'm comfortable using it at the recommended dose.
Tom, we haven't talked about ixazomib much. Are you finding a home for ixazomib, and what's the advantages of using that? This is an oral proteasome inhibitor.
I think ixazomib is a very good exchange for bortezomib. And so I use it in places where I would use bortezomib. And it's very convenient. It's convenient to just give once weekly dosing 3 out of 4 weeks. So yeah, we have been using it. We've been using it in maintenance.
What about toxicity? Do you find upper GI tox, or are you comfortable with it?
There is more, I do think there's more nausea and perhaps a little bit more rash, but the rash that patients gets, it's not really bothersome and it goes away over time. So I haven't found it hard to deal with at all, really.
What about over here, ixazomib? Your thoughts or comments?
So I have switched some patients that were on bortezomib to ixazomib, primarily people that were traveling several hours to come to see us. And it's interesting because in people with stable but detectable disease, once switching, I saw an increase in their disease burden, and putting them back on bortezomib, saw that the disease burden came back down. So I disagree slightly with what Tom said. I don't think they're actually equally exchangeable. I mean, obviously they're the same class of drugs. But as upfront therapy, I would use bortezomib. Where I do use ixazomib is in the frail patient or the patient that has a stable disease. For whatever reason, I want to use bortezomib, a proteasome inhibitor, as maintenance. And I think there, ixazomib is a very good drug.
In the randomized trial of ixazomib, lenalidomide versus lenalidomide, there was quite remarkable activity in the high-risk P53 deleted patients. Do you buy into that?
You know, I think when you're looking at the comparator arms, you know, I think RVD would probably give you, you know, similar response when you compare that to RD. So you can make the argument that a PI IMiD combination may give you similar PFS benefit, but I don't think it's an IGZA specific effect.
We talked about MRD in the frontline setting. Are people using MRD in relapse, Sagar?
We're not using it routinely. I think it's interesting because
But we said that, you know, there's all this MRD data with DRD.
Right. No, I was going to say that I think that the data we saw from Castor and Pollux was certainly the first data we've ever seen looking at MRD in the relapsed and refractory setting. If you take the 10 to the minus 6 cutoff for both of those trials, clearly the incidence was higher in the group that got DARA than the group that didn't. But you're still on the order of about 10% of patient. Yeah. So I think, you know,
it's not so many, right?
Right.
Yeah. Tom, thoughts on that?
Agreed. In the relapse refractory setting, pretty much we're stuck doing it in the 1 to 3 prior lines of therapy because you don't really achieve enough CRs in those later lines of therapy. I would say the only thing, you know, that may blow that out of the water is what Gareth said earlier is, you know, CAR T cells. Are we going to start seeing MRD negativity in CAR T cells?
You know, I have to tell you that I still see patients who come in now that are relapsing. They had CyberD transplant, lenalidomide maintenance, and I just tell them, I think you did ineffective therapy. I'm going to retreat you, and I do tell them I'm going to aim for MRD negativity with daratumumab and Kyprolis. And
I think we have the tools to do it. I think it was dangerous a few years ago because you could give people a lot of side effects, but the tools we have now are much, much better. And so I think it's a perfectly legitimate approach in relapsed and refractory patients.
You pushed the envelope in clinical